Welcome back to Rounds, Episode 6. Today we have 5 clinical cases, and for each one, the real diagnosis lies one question deeper than the first answer. We'll cover blood in the urine, joint pain, chest pain, a suspected overdose, and menstrual issues. Education only, not medical advice. Let's round. Every case follows a 6-step journey: history, examination, investigations, your decision, the reveal, and clinical pearls. For this episode, I've added a drill. After you commit to a diagnosis, ask yourself what your next question would be. Often, the difference between a good student and a good clinician is that one extra, vital follow-up question. Here is our board for today. We have 5 women, 5 distinct presentations, and 5 diagnostic puzzles. From loin pain to a suspected overdose, each case has a deeper question waiting to be asked. Let's begin with Case 1. Case 1. A 46-year-old teacher presents with 2 days of continuous, dull right loin pain and visible blood in her urine. While blood in the urine is alarming, the deeper clue is her history. This has happened before, and her family tree reveals a father who died young of a brain bleed and an uncle who needed a kidney transplant. Consider these 4 threads: a recurring, self-resolving pattern of loin pain, hypertension during pregnancy, and a family history of both brain hemorrhages and kidney failure. Bilateral, recurrent pain is the key rhythm here. The family pedigree links these seemingly unrelated organ systems. Let's look at the physical examination. On examination, she is hypertensive with evidence of long-standing vascular changes in her fundi. The abdominal exam reveals the definitive finding: palatable masses in both flanks. Remember this principle: healthy kidneys are impalpable. Feeling one is abnormal, but feeling both in this context narrows our differential significantly. Her investigations confirm impaired kidney function, yet her hemoglobin remains normal. The urine analysis shows significant bleeding without evidence of infection or stones. These findings, bilateral enlarged kidneys, chronic hypertension, and her specific family history, tell a cohesive story. Based on this, what is your diagnosis? Pause the video now. Consider, what is the diagnosis and the pattern of inheritance? Which imaging test would confirm it? And what should we be screening for given her family history? Think about the link between the kidneys and her father's cause of death. Take a moment to commit to your answer. The diagnosis is autosomal dominant polycystic kidney disease, or ADPKD. This condition causes kidneys to enlarge with fluid-filled cysts. The visible blood is likely from a ruptured cyst, which usually resolves with rest. Her family history of brain hemorrhages points to a known complication: Berry aneurysms, which are associated with this disease. The inheritance here is autosomal dominant, meaning each child has a 50% chance of inheriting the condition. Ultrasound is the preferred initial screening tool, looking for multiple renal cysts. ADPKD is a systemic disease, which is why we must also watch for complications like mitral valve prolapse, diverticula, and, critically, cerebral aneurysms. Management focuses on blood pressure control to preserve kidney function. For this patient, we must also screen her brain for aneurysms due to her family history and counsel her children. Always remember, bilateral flank masses suggest ADPKD, and family history is a vital diagnostic and screening tool. Now let's move to Case 2. Case 2 involves a 38-year-old legal secretary experiencing persistent aching in her hands and feet. The pain is worst in the morning and improves as the day progresses. She has also noticed unexplained weight loss and fatigue. This combination of symptoms suggests an underlying systemic inflammatory process. Her history reveals classic inflammatory signs: morning stiffness that eases with activity rather than mechanical wear. She finds temporary relief with anti-inflammatory medication, but the systemic symptoms of fatigue and weight loss point to a broader condition. We need to look closely at the distribution of her joint pain. The physical exam shows swelling and tenderness in the small joints of both her hands and feet. The striking symmetry of this involvement is a hallmark of certain systemic diseases. Additionally, she appears pale, suggesting an underlying anemia. The pattern of small joint symmetry combined with systemic signs is very specific. Lab investigations confirm an elevated ESR and anemia consistent with chronic inflammation. Interestingly, her creatinine is slightly elevated, prompting us to consider the long-term impact of her anti-inflammatory use. As you reflect on these results, ask yourself, what is the most likely systemic inflammatory diagnosis? Pause and commit. Case 2. Pause the video. Question 1. What is the diagnosis? And prove you know its neighbors. Which features separate it from osteoarthritis, lupus, and gout? Question 2. What is raising her creatinine? Name the culprit and then map the next steps. Which 2 blood tests and 1 X-ray region come next? Clues are on the table. The diagnosis is early rheumatoid arthritis, a systemic autoimmune inflammation of the joint lining. The key is that insidious start and symmetrical peripheral joint involvement. Unlike osteoarthritis, which loves the fingertip joints and worsens with use, rheumatoid spares those fingertip joints and is worst on waking. Symmetry and morning stiffness define the pattern. Rheumatoid is a systemic disease affecting everything from the lungs to the eyes. Regarding the creatinine, the likely culprit is her regular use of diclofenac, an NSAID. Confirmation requires checking rheumatoid factor and anti-DNA antibodies to rule out lupus, and X-rays of the hands and feet to look for the earliest erosions, often at the 5th toe. Treatment must be early, as joint damage is permanent. We use disease-modifying anti-rheumatic drugs, or DMARDs, and if those fail, biologics. Always remember, morning stiffness plus small joint symmetry equals rheumatoid. Keep an eye on the anemia and ESR as your activity dashboard, and never forget that NSAIDs touch everyone's kidneys. Always recheck that creatinine. Case 3. A 30-year-old woman with 2 years of recurrent, gripping left-sided chest pain. She is requesting an angiogram, convinced she has heart disease. This case is a test of your judgment. It's about knowing when not to escalate. The pain is left-sided, not central, radiating to the armpit. It lasts between 5 and 30 minutes and occurs at rest, especially in the evenings. The accompanying palpitations occur only after the pain starts and are described as a steady, forceful thump rather than an irregular rhythm. Note every detail, as the diagnosis is hidden in the history. Her history includes her grandfather's death from a heart attack 1 year ago. She is a medical secretary and handles cardiac records daily. She also has a history of unexplained abdominal issues. These details provide the context. She is a worried person living in a high-stress environment, and her pain follows a clear, non-cardiac pattern. On examination, her vitals are mostly normal, though her respiratory rate is slightly elevated at 22. Crucially, pressing on her chest reveals localized tenderness over the wall. Her ECG is completely normal. The patient is demanding an angiogram, but you have enough information to pause and consider a more measured approach. Pause the video. Is this ischemic heart disease? Argue your point using the pain's features. Secondly, what is your next step, and what are the risks of over-testing? Consider her family history versus the objective evidence. Make your plan. This pain fails the grammar of ischemia. It is left-sided, triggered unpredictably by stress, and accompanied by steady palpitations that result from overbreathing. Her family history is not significant at age 77. This is not cardiac disease. It is an anxiety and overbreathing pattern presenting through the chest wall. The wise plan is to reassure, acknowledge her grandfather's history, and explain why her symptoms don't match ischemia. If you must, use a graded stress test rather than an angiogram. Angiograms are invasive. Over-testing reinforces illness and ignites new anxiety. A functional diagnosis must be made on positive evidence, not just the absence of organic findings. Remember, ischemic pain is stereotyped. If it doesn't fit the pattern, look for other causes. Testing is a treatment decision that carries its own risks. Make the positive diagnosis of anxiety based on the evidence, not by default. Let's move to Case 4. Case 4. A 30-year-old woman is brought in 16 hours after locking herself in a bathroom following a threat to take pills. She denies everything, yet she has mild abdominal discomfort. She looks and acts perfectly well, which is exactly why you must remain vigilant. The history is concerning. Recent postpartum depression, a locked bathroom, and access to medications. The critical point is that no one has yet asked her directly and kindly what she took. That conversation is your first, most essential step in managing this potentially life-threatening situation. Her physical exam is unremarkable, but her labs show a prothrombin time of 18 seconds. The liver is the body's clotting factory, and its function fails fast. Even if she looks well, that prothrombin time is a silent, urgent alarm. In overdose medicine, this small change is a loud shout that requires immediate action. 3 tablets were in the house: aspirin, temazepam, and acetaminophen. Each tells a different story. Aspirin and temazepam are loud or sleepy early on, making them harder to miss. But acetaminophen is the silent one, which is exactly what makes it so dangerous. She looks fine, but the injury is already quietly building. Pause the video. Question 1. Which of these agents is our primary concern, And which 2 urgent blood tests do you send right now? Question 2. What is the specific antidote? Is 16 hours post-ingestion too late for it? And what else must you manage beyond just the liver? Commit to your answers. The reveal. It is an acetaminophen overdose. Her blood level was high, and the rising PT confirmed early liver injury. Remember the timeline. The first 24 hours are deceptively quiet. Peak injury happens on days 3 to 4. Always treat based on the protocol, not just how she looks in the first hours. Treating this patient means rescuing both the liver and the life. Give intravenous acetylcysteine immediately. It is still effective at 16 hours. Beyond the antidote, you must manage her safely. A mandatory psychiatric assessment is required, alongside a thoughtful evaluation of her situation at home with her young son. 3 pearls. Acetaminophen is the silent overdose, so do not let a well-looking patient fool you. The PTINR is your earliest smoke alarm. Unexplained clotting derangement requires an immediate level. Finally, the antidote works late. Give it. And never forget that every overdose has 2 patients, the organ and the person. Case 5. A 23-year-old actress presents with 5 months of secondary amenorrhea and an 8-kilogram weight loss. She mentions her appetite is good, but her pulse is only 52. As always, the words tell one story, but her body chemistry is about to reveal a much different truth. Listen to what is between the lines. Secondary amenorrhea in a previously regular woman needs careful investigation. Her weight loss, combined with the stress of a recent breakup and her image-conscious profession, are significant context. But notice her claim, "My appetite is good." That phrase is often a signal to look deeper. Her physical exam is a study in conservation. A BMI of 14, bradycardia, and low blood pressure. Look for lanugo, that fine, downy hair, and signs of muscle wasting. Her body is essentially in famine survival mode, shutting down non-essential functions, including reproduction, to save energy. The examination points clearly to an eating disorder. The chemistry is the final testimony. Her potassium is low, her chloride is low, and her bicarbonate is high. This triad is a classic fingerprint of self-induced vomiting. The body is telling you exactly what is happening, even if the patient is not ready to admit it herself. Final pause of the episode. Question 1. What is the diagnosis and what behavior does the electrolyte pattern reveal? Question 2. Which other causes of secondary amenorrhea must you rule out? What would the hormone profile show, and what is the core of your management approach? Think deeply and kindly. The diagnosis is anorexia nervosa. It is an illness, not a choice. The electrolyte pattern confirms recurrent vomiting. The bradycardia, hypotension, and hormonal suppression are all physiological consequences of severe starvation. Urine chloride can help distinguish between vomiting and diuretic misuse, but the overall picture is clear. Complete the picture by looking for Russell's sign, calluses on the knuckles from self-induced vomiting, and eroded dental enamel. Real danger lies in her potassium, which puts her at risk for life-threatening arrhythmias. Before you conclude, you must exclude other causes like thyroid or pituitary disease to be certain of your diagnosis. Management requires a multidisciplinary team. Refeeding must be done carefully to avoid complications. Supportive psychotherapy is essential to address the disordered body image that drives the disease. Pearls to remember. Always weigh and ask about eating in amenorrhea cases. The electrolyte triad is a fingerprint, and lead with compassion. Today we covered 5 cases that moved from the first superficial answer to the deeper clinical reality. Whether it was genetic disease, inflammation, functional pain, overdose, or an eating disorder, the lesson remains the same. The truth is often hidden in the details. Keep asking that one extra question. Rounds are complete. Thank you for joining me for these 30 cases across 6 episodes. If these sessions have helped sharpen your clinical reasoning, please subscribe and share. New patients will arrive in the next series, and there will always be more to uncover. For education only, not medical advice. See you next time.